Hi, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of the Section of General Thoracic Surgery at Emory University Hospital in Atlanta. So, oftentimes we might see other lung nodules, on the preoperative CAT scan that may be smaller but concerning that are in addition to the primary lung cancer that's been diagnosed, or even sometimes we find out when we're in the operating room. Like that didn't show up on the scan, but we see another spot. Or another example may be that you have a tumor in one lobe, say the right upper lobe, that is actually growing across the fissure into the upper part of the superior segment of the lower lobe. So how do you deal with those situations, either in your preoperative planning or when you're, hopefully we're not surprised that much in the operating room, but you've got to be prepared for any situation. So typically, if a patient, say, had a 3 centimeter right upper lobe tumor and then another 1 centimeter right middle lobe lung nodule, there's different ways to handle that. You certainly could take out the right upper lobe and the middle lobe, but I think if it's a small spot, a small nodule, a centimeter or less, most of us would go ahead and do the formal lobectomy, where the primary larger cancer is, and then a wedge resection, if possible, on the smaller lesion. If it's crossing the fissure, then we would take out the primary tumor and then either do what we call an en bloc. So we're doing a wedge resection while that tumor is still connected to the upper lobe that's been taken off. Or sometimes you can combine a lobectomy with a segmentectomy, and we'll take out the upper segment or superior segment of the lower lobe. It's gotten even more complicated in a good way now that we have good radiation techniques. So it may be that a patient's really, has a bigger primary upper lobe cancer and then a little tiny, 9 millimeter nodule in the lower lobe that may be a cancer, but it's very deep and we can't really biopsy it. So we might say, well, hey, we're just going to take out the cancer, surveil this patient, assuming they don't need any chemotherapy. And if the other one starts to grow, we can biopsy it and do localized or stereotactic radiation to it if they're not a candidate to remove the rest of that lung. So there's a lot of strategies for dealing with other nodules. And what we're finding too, and whether it's because of better imaging or just the patients that are coming through in terms of age, but we're finding a lot more multifocal lung cancers. And so these are cancers that, primary cancers that are showing up in multiple lobes at the same time. And I explain it to patients, I say, if you've been exposed to the sun your whole life, you're likely to get multiple skin cancers. You don't just get one skin cancer, you get one on your arm and one on your nose. Well, it's surprising that more people who have been heavy smokers don't get multifocal lung cancer because all their lungs have been exposed to smoke. And so you would actually expect more of it than we see. And so that creates like a different strategy for the patient and the provider because, oftentimes these patients are incorrectly diagnosed with metastatic lung cancer. So you have two spots, one in the left lower lobe and one in the right upper lobe, and it's, oh, they have stage 4 cancer. Well, that may not be the case. And it's really critical that they're biopsied, that we look at the growth rates, and we determine whether it's stage 4 or just two synchronous stage 1 cancers that can be treated, with either surgery and radiation or, depending on how we're going to do it.